So what you're saying is I'm not drinking enough coffee.
I'm
into it.
My guess would be that yours are strong enough to qualify into the...
As a couple cups
yes,
each?
I would guess you qualify for the 4 to 5 range.
This is Generation Health. Every week we bring you the latest in news, cutting-edge research, and time-tested best practices helping you live a longer, healthier life. Sitting to my right, Mr. Dante DiMatteo, registered pharmacist, certified strength and conditioning specialist, looking very good in that black t-shirt, sir. How are you?
Hey, you too. Thank you.
Oh, look at that. And across from us, Joey DiMatteo, registered pharmacist, board certified clinical nutritionist. How are you?
Very good. How are you today, Tyler?
I'm doing great.
Happy to be here.
Yeah. Today this is a fun show. We're going to talk about MDMA for PTSD. We're going to talk about when exercise matters and why, not when exercise matters, when you exercise matters. That's what I'm trying to say. And calorie counting to reduce cancer deaths. Interesting research there. Certainly something we're going to talk about. But first, and I mean, this is really the question everybody's been wondering for ages. Joey, would you trade 10% of your sanity to be 10% smarter?
That's really hard to kind of quantify. Like, I can't quite pinpoint what the manifestations of either one of those would be.
Would you be willing to be slightly crazy?
Right.
To be...
No, I get it. Again, I just can't really play that out, except for I'm going to lean no, I think.
Okay, all right.
Yeah, I think I'm going to definitely lean no.
Since you leveled talking about movies, and this is obviously where I can go with this. I think of A Beautiful Mind with Russell Crowe and Jennifer Connelly.
That's an extreme example, but okay, yeah.
Would you be willing to go through that to be that smart?
No.
Okay.
No. I do think that, like, playing with the numbers, you can get different answers. Like,
I would do 7%, but not 10.
Well, yeah, or even more extreme. Like, well, I would do 10% of my sanity if I get 25% smarter. Like,
a disproportionate return.
Yes, exactly.
Got it.
If I can play with the scale,
okay.
I think I could be convinced. But at 10 and 10, I don't know. I'm a little scared of that.
There's an acceptable level of sanity that you would trade off.
Yes.
Got it. Okay.
I probably got a little craziness already, so I don't want to push it too much.
Fair enough. Dante?
Yeah, I mean, the last part is like kind of how I was feeling. Like, I feel like I'm already a little bit nuts already.
Yeah.
That like, what's like 10% more
definitely.
Do?
Yeah. I think for you, 100%. Yeah, that would be.
So
I would spare.
I'd probably say, yeah, I probably would do it.
I would not. I would definitely not.
I really was curious about what your guys' answers would be.
I would definitely not. I would like to think that I would because my ego, but I don't think it's worth it.
I guess I'm more scared about what 10% loss of sanity would do than what I truly believe how I can manifest 10 more percent of intensity. Now, if you say I'm 18 and a half years old, I'm starting college, then again, there are some caveats here. Would I maybe do it at 10 and 10 at 18 and I'm about to go into a chosen field or get through college, or maybe that helps me.
Oh, man.
But, I just don't know what exactly, like, right now being 10% smarter would do versus losing 10% of sanity, I don't know. That's why I go no, I guess.
I think it's a fun question.
It is. I took it to different levels, I guess.
What are the consequences of being 10% less sane? Is that just that people look at you like funny, or is that men in nice white coats? It's hard to know. Yeah. Does that harm some of your relationships or something? Yeah.
Or, I don't know. I guess that's right.
It definitely would.
Yeah.
I mean, that's how sanity plays itself out, is in relationships with other people.
And what would 10% being 10% smarter do in that regard? You
just got to find the other crazy smart people.
Sure. 10, 25, I'll go with. 10, 10, maybe at 18.
We're assuming like we're smart enough, like this 10%.
It's true.
It might take me to like,
your IQ of 80, it puts you at 88 now. Congratulations. Yeah. You can tie your shoes. Good job. Oh my gosh. All right. So getting into the real stuff here, we got an email in from Manuel. He emailed us at questions@askjoedimatteo. You can email us there too. He emailed simply and said, "What do you recommend for prostate health? I am 59 years old."
Yeah, so it's definitely a good question. As, happens with a lot of these, more information will be helpful. I think too, this one's super broad.
Yep.
Because he's at 59. Is he saying, but what do you recommend for prostate health because XYZ, I'm experiencing this, I've got this risk. So we don't know any of that. So, obviously then only direction to go was broad in response. So generally, if you're 40 to 45, which that was startlingly young to me.
Really?
I'm 40, so that was like startling. If you are at higher risk, which being African-American is enough to check that box. If you have a brother or father with a history of prostate cancer, this one's a little more difficult. Or if you have a variant in the BRCA2 gene, which
if you've had your genetics run.
Exactly. So that's, not real useful, but brother, father, or just being African-American, you should get a PSA at 40 to 45.
Really? Well, that's me.
That was jarring. Yeah. And then, Manuel, for you at 59, you hit it either way.
Yep.
So, 55 to 69 is kind of the sweet spot. This is one of those interesting things where they don't recommend screening over 70. Again, screening is you have no symptoms. You just get tested because you hit a certain criteria or age. So they don't, obviously, if you're having major symptoms over 70, you're going to go deal with it. It's not saying just let your prostate ride. But from 55 to 69 is whenever they recommend actual screening. So he's in that. So number one, get your PSA done. It is a little nebulous. There's no exact numbers, but they can tell when it's a little out of whack high. And then also it gives them a baseline to be able to test periodically
down the road.
Yes. To see what your level changes.
Got it.
But again, it's not a black or white, you're supposed to be within 10 to 20 and you're at 25. So it's a little nebulous, but it's still a very valuable tool. And then from there, if there are any concerns, you get a digital rectal exam, which, and then also you would get a biopsy.
We don't do those at the pharmacy, right?
Yeah, I'm going to gloss over that one, but that is an important one. Had to be mentioned on a science show.
Assuming that he's healthy, assuming that Manuel is just a typical 59-year-old guy who maybe he's waking up to go to the bathroom in the middle of the night or other things like that. There's nothing major, but he's older and he's going, I should probably think about taking care of this now before it gets bad.
Yeah. I mean, we can assume that if he's going online to our site and asking the question that there's something there, either historically or like you mentioned, symptomology wise. So, it comes back to a lot of, and even I was a little surprised, still lifestyle when it comes to prostate cancer.
Okay.
I mean, this is not necessarily going to help. I'm going to eat more whole foods, fruits and vegetables, lycopene and tomatoes, and now I'm going to stop having, the urinary frequency at night. It's not like that 1-to-1, but when you're looking at prostate cancer, it's a lot of the things that come up in nearly every, broad health topic issue, that we talk about. Cutting saturated fats, smokers are at higher risk. This one was interesting, heavy dairy consumption. Not sure if it's the calcium link or potentially a hormone link, but heavy dairy consumption, not just dairy consumption in general, but heavy dairy consumption has been associated with increased incidence of prostate cancer risk. Exercise been, another one, decreases the risk. This one was interesting though, coffee. 2 separate studies, one studied at 3 cups, one studied at 4 or 5. 3 cups lowered risk of prostate cancer incidence, lowered. 4 to 5 cups lowered the severity and lethality of prostate cancer.
So what you're saying is I'm not drinking enough coffee.
I'm into it. My guess would be that yours are strong enough to qualify into the
as a couple cups.
Yes, I would guess you qualify for the 4 to 5 range. But so there's the lifestyle issues right there. I don't want to go too deep in other things, like the medications, because that's if
right.
But there are supplements that you can take that again at 59, and if you are having some of the symptoms that can help. They're mainly going to contain something like saw palmetto, pygeum, the lycopene I kind of mentioned with the red fruits and tomatoes, etc. Pumpkin seed oil. Those things have all been shown to help. We do combine them in ours in the Prostate Essentials.
We've got a specific targeted product.
Yes, that does combine all those different ingredients that you may have read about. If you're having specific symptomology, a lot of frequent urination, you're almost, definitely sure that there's some, some pressure from the prostate on some of the urinary, that's where the issues come in. You get those sensations of that your bladder is not emptying. You're frequently having the urge to go, even if there's not a whole lot that's coming out, that weak stream, those kind of things. There's another product called Prostablock that does help with the symptomology if it's become a little more advanced.
Okay.
So that's going to have more of a turmeric kind of main ingredient there that approaches it more from an anti-inflammatory way. Skullcap, Bruta Chinese herb, and propolis. So those are, the two supplement products in general. Also zinc, which I've read because it's always kind of associated with male health, and sometimes, you almost need to reset on, because you just become so used to saying male health zinc or testosterone zinc.
Yeah.
I look back into why, and it actually accumulates in high levels with the prostate. It's involved in critical activity. This gets the specifics of it get very scientific, but it accumulates in the prostate. It's responsible for some of the Krebs cycle activity that occurs inside of the prostate, blocking a certain metabolite. It was really, really interesting to see that how zinc literally needs to be in high levels and accumulates in the prostate. So that's, direct link there. You don't want to do mega doses. There was some almost paradoxical issues that we saw with mega doses, so don't do that. But 25 to 50 milligrams a day. There is 20 in our prostate essentials, so if you are taking that, you could go to 1 a day if you wanted, but I think going from 50 to 70 would be fine. But you don't want to do mega doses of zinc. Again, we see a lot of, well, I have this issue and this is right. Just a nutrient. I'm gonna take a bunch of it. Watch with zinc. There's some smoke out there that doing mega doses is not the best thing for you. So
fair enough.
That's, kind of tough. And if you're going to do a medication, if things have kind of crossed over for you, I'm not going to go into God forbid, prostate cancer things, but the symptomology, try to stick with something like a Flomax or a Uroxetrol, the Zosyn drugs. Those are alpha blockers. They can be used for blood pressure, but these ones used for prostate have been found to be very specific to the vasculature in the urogenital tract. So it's not going to have as much blood pressure effect as some of the early alpha blockers. So it's pretty unique, in kind of the drug discovery phase. These were probably started as blood pressure drugs, but then they found that they're kind of specific to the receptors in that area.
Wow.
So those aren't going to have really the side effects that something that has a little bit of a heavier hitter like a finasteride, which is blocking the conversion of testosterone to DHT. Dihydrotestosterone, DHT, is a very potent form of testosterone, and it's also associated with, along with your genetics, hair loss, as well as prostate inflammation over time. So that blocks it, but the DHT is still involved in a lot of male testosterone.
Other things.
Yes.
Yeah.
So when you start blocking that, you can have some of the sexual side effects, even down the line, bone issues, et cetera. So if you can avoid going into the heavier class,
right.
And you can get some symptom relief with a supplement and or one of the milder meds and some of the, pretty basic lifestyle recommendations, that's probably a, good starter point for prostate health.
All right. So to sum up, you're 59, go get checked. Have some screening done, get your PSA and potentially the other check. If it's general symptomology, you're just trying to stay healthy, our prostate essentials are great. And then the what was the other one?
Prostablock, if things start to get a little more advanced.
Right.
Yeah.
And then there are some lighter medications that can help as well, without all the heavy hitting side effects.
Yep. Flomax, Uroxetrol, mainly Flomax. You can stick with that.
I like it. Makes a lot of sense. I hope that helps, Manuel. All right. Next up, we've got an article about exercise timing. This didn't even occur to me. And then I read the article and I have a feeling I know what you're going to say right off the bat, but it's going to be fun anyway. The secret of getting more out of exercise. This is from The Guardian. But the latest science, I'm jumping ahead a little in the article, but the latest science of chrono-exercise, sometimes called chronoactivity, suggests that what really counts isn't what we do or even how we do it, but when we do it. Of course, moving at any time of the day is good, but we now know that our bodies and brains change over the course of 24 hours with chemicals, proteins, and hormones ebbing and flowing almost hour by hour. So perhaps it's hardly surprising that a string of new studies suggests that timing our exercise to optimally match our body's circadian rhythms could reap additional rewards. And that means faster results and less time at the gym. A new study published in the European Journal of Preventative Cardiology found that for those of us wanting to fend off heart disease and stroke, the optimal time of day to move is between 8 a.m. and 11 a.m., and preferably closer to 11 a.m. Quote, "The late morning seems to be the most ideal timing," unquote, explained the study author Gali Albalak. That research found that women appeared to benefit the most, reflecting earlier studies that also found morning to be a particularly effective time for females. A report from Skidmore College in the US found that women who exercised in the morning shed more abdominal fat than women who exercised later in the day. To boot, the female morning movers were also more likely to lower their blood pressure. But when it comes to men, or those with type 2 diabetes, the data shows a different picture. The Skidmore College researchers found that the men who exercised later in the day markedly reduced their blood pressure, cholesterol, body fat, and feelings of fatigue. Multiple studies suggest that afternoon and evening are the best time to do this. Our muscles increase in strength throughout the day, so that by late afternoon, they are at peak fortitude, enabling us to lift more for longer, which means, very simply, that we build muscle more effectively and efficiently and with less perceived effort toward the end of the day. Again, studies indicate that the benefits of resistance and strength training done in the evening are more pronounced for women, although it's not clear why. All right, that's all we're reading of that. Dante, got any thoughts?
Yeah, definitely. I mean, I think this type of research is fascinating, and it always leads to the initiation of more trials, more specific interventions.
Right, but based on this, I have to completely change the way I'm doing everything. I've got to be running in the morning and lifting weights at night.
Well, I would say at the outset, I still have no strong recommendation, nor would any, clinician have a strong recommendation change after something like this. It just might, I don't know. It might, I think in a conversation with a patient or with a client, who they say, you know what, I feel great in the mornings, but is that a good time to work out? What do you think? What should I be doing? Then this might be a feather in your cap to say, hey, maybe there's a benefit in addition to there's a benefit in terms of cardiovascular risk if you decide to, primarily exercise in the mornings. But
right.
I still don't think this is a recommendation changing, observational study.
Yeah.
So I think at best, just given the nature of it being an observational study, it gives us that foundation for, future interventions to try and make. So I think that's a good segue into some of the limitations. And in my opinion, with the study specifically, the biggest would be, and I'll just quote what they said.
Yeah.
We were not able to retrieve the nature of the observed acceleration, example, leisure or work-related activity. Although having this information may lead to a better understanding of the observed association, according to the latest WHO report on physical activity, there is no effect difference between leisure or work-related activity on health. And so
basically,
basically what that's saying is they wore these accelerometers, and it essentially just in those 7 days that they were wearing them, it just picked up on when it could tell that they were moving more than baseline.
Got it.
So somebody may have just had a very active job, manual labor, something they're on their feet all the time, and that got flagged, so to speak, as their exercise.
Okay.
And yeah, like what the WHO is saying is true. There's no effect difference between leisure or work-related activity on health. I guess that's true, but that's still another example where the overarching body of evidence and the overarching recommendations, even in the physical activity guideline recommendations, that it's still best to find something that's deliberate exercise. You know what I mean? And so with that, there's a, kind of a dose dependent relationship with what you're doing. So, so it's your resistance training 1 day a week. If you push that to 2 days a week, that's great. If you push it to 3 days a week, that might be even better.
Right.
And so all of that's to say, it's a valid point, but I think that that's a huge limitation because you're just seeing how somebody's moving. You don't actually know what they're doing. Like what if we studied people who were on a, very well thought out training program. They were resistance training and covering all major body parts twice a week.
Right.
What kind of outcomes then are you seeing? That's what I believe is not been totally parsed out yet. And then also it's like the easy sort of tongue in cheek thing to say is like, well, this is going to discourage this is going to discourage people from their evening workout. It's going to say, well, if it's better in the morning, then what the heck's the point of me?
Well, it said for men, lifting weights at night is better. Right. And I can only exercise in the morning. That's the only time that I can do it. So I guess why am I even bothering?
That's right. That's exactly it. Yeah. So it's tough. And then again, in terms of chrono activity, chrono nutrition is another big thing that we've talked about. When should I be eating in relation to exercise or in relation to my hormone levels and all that kind of stuff. Still just a very, nuanced conversation. And for the vast majority of people, it's probably still just a little too complicated when you're talking about just basic behavioral,
a little
lifestyle
too esoteric,
changes.
A little too like playing around the edges.
Definitely.
If you can get the right amount of protein in during the day, that's going to be more impactful than making sure that you eat it within the percent time of round your exercise or whatever.
Right.
Got it.
Right. And then also they even mentioned, if I interpreted this correctly, they followed up on the cardiac and stroke events.
Yep.
During after a 6-year follow-up, but they only measured the activity over those initial 7 days, I guess.
Oh, wow. So they're drawing some pretty big, broad conclusions based on 7 days.
Yeah. And I don't want to say that just totally like that invalidates what's happening here. I don't know. I think the more information, the type of exercise, if they did this 7-day study every 6 months or, the 7-day activity measurement every 6 months, every 3 months, I don't know. I think that might reveal something else. Like they also didn't take into account like socioeconomic status, which also has a role with cardiovascular rates.
For sure.
They didn't differentiate like necessarily the exercise intensity.
Wow.
So there's so many little things here, and I don't know. So
they're taking a little bit of data and drawing some really broad conclusions and writing headlines based on that.
Sure. I don't know. It's just to like, I don't know. It provides a very interesting conversation.
Yeah.
There's no doubt about that. I would say it's for me, who's always interested in this stuff, it's a fascinating thing to think about. And I exercise primarily in the mornings. And so it makes me consider different things.
Sure.
And then also, even if we shift gears away from cardiovascular health outcomes, which this is focused on,
right?
A lot of the other research that's been done looked at things more from a performance standpoint, whereas these are specific health markers. A lot of the studies that look at the chronoactivity differences show that some of the studies show that there might be a bit of a difference in muscle growth in night versus morning training. Might be a little bit better to wait till later in the day, but even a lot of those findings were not incredibly strong.
Right.
It's just, again, it's something to use for future research. And then there was even another one that showed changes in size and strength gains. They were incredibly similar over the long term in people who do stuff in the morning versus doing stuff in the evening. The biggest differences in this that you'll see is if, somebody has been training their whole life in the evening, they're more of a nighttime person, a nightly chronotype, so to speak.
Yeah.
Then all of a sudden their job changes or their family changes and they got to go to everything's in the morning now.
Yeah.
There's some studies that show there's like a 5 to 10% decrease in strength or 5 to 10% decrease in whatever like performance metric that you're looking at in a certain window of time as you're trying to make that change.
That makes sense.
But then you extrapolate that over the long term, which is what we care about.
Right.
There's really not a huge difference.
Fair enough.
So, and then also it's like my bias, at least right now in 2023, is a little more of the CrossFit stuff. That's a sport that, we're talking performance, we're talking sport. You're you go to a competition, you might have multiple events. It might start at 8 a.m. and then you have an event at 3 p.m. And then you have to do one the next day at 8, and maybe there's 3 events. Who knows?
Right.
You have to figure out a way to become resilient and just get it done.
Yeah.
And I'm not saying that everybody needs to be a competitor,
right?
But we have to also, like, regardless of all this stuff, we have enough, even in terms of an evidence-based perspective, that we are adaptable enough to figure out, like, if my schedule changes, it's going to take some time. I can go from morning to night, or if my schedule changes, I can go from night to morning. There might be some decrements, some frustrations, some changes in how I perceive how the weight feels or the jogging feels and all that kind of stuff. But the big picture is, we look at this on a long-term trajectory, and there might be some ebbs and flows, but as long as that thing's still going up, that to me is what the overarching research shows, is that there's some things in the minutia that you can nitpick, especially if you're a competitor, running in the morning versus lifting at night, or, if you have a strength session, maybe you do that while you're more fresh, or if running means more to you currently, then front load with running. However you can swing that. There's just a huge conversation to be had about, okay, health metrics, performance metrics, personal preference, convenience, scheduling, somebody's adherence. It's more than just like, this potentially is going to reduce my
stroke. 5% greater gain if you do it at 4:27 p.m.
Right. Yeah, maybe if you work from home and you have, your schedule's very adaptable, or you're a professional athlete and it's all about maximizing. I totally get that. But for the average person who's kind of tied to work and family commitments, I think it's really hard to totally shift decisions based on that. I know Dante covered the nuts and bolts, but for somebody with kids and all those things and 9 to 5-ish type job, it's like, I know for me, it's morning or bust. There's just, after a long day, and then my responsibilities change in the evening, there's just no way.
So the punchline is, go exercise. That's the point. It doesn't matter what time it is. Don't let a fun headline like this throw you. It's more important that you exercise. It's more important that you do it consistently over a long period of time. Doesn't matter as much the time of day, but if you're in the top 2% of athletes and you really want to fine tune it, and you're debating whether you get, the chicken thigh versus the chicken leg, and that determines your macros for the week, sure, knock yourself out, change your diet, your exercise schedule based on these chronological factors. But for most people, calm down, folks. It's okay. It's just a headline. It won't hurt you.
Exactly. Yeah.
Very good. All right. Well, we're going to move on to psychedelics.
Quite a change of gears.
This, it's coming from the New York Post. There's actually a bunch of articles about this, but this was the one that grabbed my attention. MDMA expected to be approved by the FDA. The U.S. Food and Drug Administration will be asked to approve MDMA. Yes, the illicit drug. They were expected to approve the MDMA to treat post-traumatic stress disorder by October of 2023, opening the door to the use of hallucinogenic drugs to treat mental illness. If approved, the drug will be available in hospitals before the second half of next year, according to new research. MDMA, also known as ecstasy or Molly, is a popular drug in rave culture, with people taking it to connect with the music and dance the night away. However, that's the article. I didn't make that up. However, a 2021 clinical trial for the nonprofit organization Multiple Disciplinary Association for Psychedelic Studies showed that out of the 90 people who suffered from post-traumatic stress disorder, those who took MDMA paired with psychotherapy were twice as likely to recover compared to those who did psychotherapy with a placebo, according to the journal Nature. That's all we need to read of that. I just want to start out by going, how many people do you think were tricked by the placebo into thinking that they actually had taken MDMA? I'm going to go with zero.
Zero.
Yeah.
That's where, blinded studies, 2 of them, I believe, are required by the FDA, at least 2. And it's impossible to blind in something like this.
That's a funny, I know they have to do it, but I can't imagine somebody takes a pill and then just lays there thinking it's going to hit any minute now, right?
Yeah. And then the other thing is bias of people who want to be in the study.
Right.
Probably are going into their therapy session a little upset they didn't get it because they know they didn't, or ready to kind of raring to go, so to say, because they got it and they wanted it, and that's why they entered this study. So I think there's that difficulty too.
Those are the negatives. Let's talk about the positives first before we get rid of all of this.
Definitely.
What is PTSD?
So in a nutshell, PTSD is a mental health problem, obviously, but it develops after experiencing or witnessing a life-threatening or traumatic event. So, I think it's pretty obvious, from that standpoint. It's a lot of people coming home from war, or they have these obvious, traumatic events that have happened to them as children, or, as later in life, or whatever the case may be. So if the symptoms last, obviously, sadly, a lot of people have gone through things like this, but if the symptoms last for more than a few months, then it may be classified as PTSD. This includes vivid flashbacks, intrusive thoughts of the action, nightmares, waking you up in the middle of the night about the issue, distress at any reminder or any symbolic reminder of the trauma. And then there's even just physical manifestations, nausea, trembling, sweating, things like that, where there's chemicals in your body doing things that you're not realizing, but you've been triggered by a memory or a symbolic event. So
so not just normal stress.
Right.
There's a normal stress response. This is for folks that it's been ongoing for months and years.
Correct. Yeah, and there's a clear source of why. This is not a chronically stressed person, or a person who's had a few bad relationships. These are major events,
like war.
Yes,
makes sense. But I mean, come on,
abuse, things like that.
Street drugs for the mentally ill. This does not seem like that's always what I was told, is that they were self-medicating, and that's a bad idea. So now we're just helping them with that. Is that what's going on here?
Well, I mean, that's an interesting. Definitely an interesting point. I think that for anybody that's read or heard about the How to Change Your Mind book, Michael Pollan, which is interesting. It's been a few years since I read that. My biggest takeaway at this point, after not having looked at it for a while, was just sort of the destigmatization of all of those sorts of medications. The marijuana use, psychedelic use, the potential benefits of psychedelics. I think a lot of us, that's our reaction. Yeah. And I'm not saying that like I really have a strong opinion one way or the other with it at this point.
Right.
But I think that the stock opinion is just that the misuse over time. And I know that's more, talking psilocybin and LSD and what, all that end of the spectrum.
Right.
I think it's hard to still undo a lot of that. You picture the 60s,
right?
60s and 70s, and you have a hard time dissociating that part of it. But there's certainly merits, biochemically at what's happening at the level of the brain, and why this makes sense and why this has potential utility for some people. But I think it's going to continue to be trial and error over time. There's still not really a whole lot of long-term outcome data because, again, the stigmatization prevented a lot of these trials that were occurring way back to not even really get off the ground. And so finally it's starting to ramp up again.
Am I right in remembering that the history was something along the lines of, in the 40s and 50s, when these molecules were discovered, there was some legitimate research being done on them, and then things got way out of hand. And because there's no laws against it, so it got way out of hand. They put a bunch of laws in place and just said, stop it. Nobody can touch it. Don't even think about it.
Yeah.
And they're starting to relax that now and go, okay, well, maybe in clinical situations, there's a reasonable use case for this.
And then specifically here, part of the problem that I see is that MDMA has, because it's used at clubs and raves,
right?
It's really, it's to kind of get that, you can have that feeling of like camaraderie with people that you're around. It is kind of stimulating, but it is kind of releasing serotonin. We'll get to that.
Yeah.
But it's really like, it's the sensations of light and sound. It's not, my point is, it's not a hallucinogen, and it's gotten lumped in because because it's like you're saying, the chemical structures, these chemicals were found similar time. This one actually was discovered in 1912, but its studying was it was around that time. So it's gotten lumped in. Even the society or the organization that's doing the studies has the word psychedelic in there.
Right.
This is not a psychedelic drug to me. Yes, it increases a little bit of your perception of music, noise, and sound, but it's not a psychedelic. When you start looking at LSD and psilocybin, almost you're entering in like this alternate reality. You are off planet Earth. If you try to talk to somebody, it's a totally different thing to me. It's a psychoactive drug.
Right.
It is not a psychedelic drug to me. So, I'm just starting there in my opinion.
Sure.
These drugs are very different from each other, even in their own little category, which I think is flawed. Secondarily, and this would to me apply to the LSD and psilocybin as well, but they are drugs heavily abused with an extreme abuse potential, but not an addiction potential.
Okay.
You can be psychologically addicted to anything, to food, to gambling, okay? So yes, if you take this and you really like it and it's something that you've latched onto, it can happen. I'm not,
sure.
I don't want somebody to send this nasty email about, a relative that's okay. But in general, when you're comparing Schedule 1 or Schedule 2, the most controlled medications or chemicals, you're talking cocaine and heroin and oxycodone, legal drugs.
Yep.
Okay. And some of them legal, obviously, and you're comparing them, their addiction potential, the process
physiological
addiction.
Yes.
When I start taking this, both psychologically and physiologically and physically, I'm going to have a really hard time stopping. When you compare those types with the LSD types and the MDMA types, to me, you're in a whole different ballgame.
Okay.
Again, both very high abuse potential. Only one of those categories to me, and I think it's pretty documented, has high addiction potential.
Okay, so that is a little bit of apples and oranges, and it's fascinating because we do already have all those drugs that you mentioned that are fully legal, and obviously we have lots of ramifications and problems with them now. But
yes,
we're not adding to that with this. This is a different animal, so to speak.
And I want to be clear, if you take too much of this, if you drink way too much water with this, if you are buying it on the street and you're getting adulterants in there, I am not saying that this is just something you just, this is like some wrongfully coded drug. I'm not saying that. I'm going down the line, first comparing it with other psychedelics, then comparing it with other drugs in similar control categories.
Got it.
And that's, again, there's certainly, very concerned about people getting this on the street and what the manifestations of that can be. And also, yes, if you are taking this very often, they've even found potentially that there are chemical changes in the serotonin receptors and in parts of the brain. So this is a heavy drug. Let me make that clear as I've kind of talked it up, so to say, over the last few minutes.
Yeah.
Let me make that clear before, we go on.
And nobody is suggesting, the article isn't even saying that you'd get a prescription for this and then you'd go home and take 2 a.m. every day for a month.
Exactly. These are therapy assisted drugs, as the same, we've seen this with psilocybin, and maybe we'll, talk about that one too. There's gonna be some similarities, but these are done in sessions. I believe this study, there were 3 sessions, with very little dropout, which is interesting. Again, I still would like to see, I'm assuming that the people who signed up for this, wanted to be in this, but may not just be for reasons if they wanted to try the drug. They may be really suffering.
Yeah.
I mean,
if you've got PTSD,
I was going to say they are really suffering.
Yeah. So how does it, without getting too granular, how exactly does this work? It's not just that people are getting high and then they feel better. You said it's with therapy, right?
Right. So one way addiction, the tie of it, all addictions, food to gambling to heroin to cocaine, is dopamine. That's the reward chemical that ties in everything. People getting addicted to running or whatever. That's how that's kind of the tie. And so something like food is not directly releasing dopamine. It's your body's response is to release some dopamine. But when you take a drug like cocaine, or in a mild form like MDMA, you're literally biochemically releasing dopamine.
Okay.
And so that happens more in certain drugs than others. So there's a mild case of that here with MDMA, but it's much more focused on serotonin. That's where you get kind of the feel good, the camaraderie type thing. It's a serotonin
It's a bonding drug, right? Or a hormone, right?
Yes. So what it does, so if you compare it to, which I think is important, to an SSRI, serotonin specific reuptake inhibitor. So what that's doing is whenever there's two neurons trying to talk to each other, and it releases serotonin, it kind of leaves it in that talking form instead of bringing it back.
Okay.
But it's not making it release anymore. It tries to make it a little more effective. Okay. Well, MDMA does that and also dumps serotonin.
So it does both.
It does both.
Okay.
So that's why, well, what's the difference? Well, you're saying all this, then what's the difference between that and my Prozac? That's the difference. There's a dumping of serotonin. So then what also can come with that is, after effects, especially at higher doses, you can feel a little down, you can feel a little dragging a little bit, little anxiety, those kind of things come with it. Again, it is a heavy drug.
Yeah.
So a little bit about the dopamine. The main thing is the serotonin. And then thirdly, it does hit norepinephrine, which is, kind of that stimulant, one of the stimulant neurotransmitters. So it hits some of that as well. So you do get that little bit of energy that kind of can, again, why it's associated with some of the club stuff and rave stuff.
So is the thinking then that people are taking this and in therapy sessions, they're getting those positive hormones and they're able to more safely, emotionally safely, they feel more stable in exploring and going through the trauma that's happened?
That little bit of that neurotransmitter, norepinephrine release that can be almost anxiety inducing, is way overridden by the intense serotonin release. Okay. Because what happens is whenever you're talking about these awful traumatic events, your body goes into fight or flight mode.
Got it.
So it's all of your excitatory neurotransmitters firing, and your inhibitory ones like serotonin and GABA are not firing. So you take this and you start firing these inhibitory ones to go along with the natural response that you're having of the fight or flight ones. And that's where it allows people to make sense to have more of a productive therapy session.
Got it. That makes sense. And that helps me to clear it up. It's not just a bunch of people that want to get high and are doing it for fun. So
They say in general with treating PTSD, it's best treated when a patient's in the quote unquote optimal arousal zone. And so they say this is the zone in which emotions are engaged, yet not overwhelming. In this zone, 4 symptom clusters of PTSD are sedated. And so people are re-experiencing, they're avoiding negative alterations in cognition and mood, alterations in arousal and reactivity. So something that lowers all of that stuff and allows somebody to enter what they call the optimal arousal zone a little more readily because its ability to increase empathy and closeness and all that kind of stuff. And I think that's why they lump them all together, just because of those properties. But yes, if you start pushing the doses and doing different things with them, you're dealing with much different effects.
Right. So this is not something that a doctor is going to, even if it's approved by the FDA in October, this is not something that a doctor is just going to write a script or a psychiatrist and bring it to you guys at the medicine shop and somebody's going to go home with MDMA.
No.
Okay. All right. I guess the only other question I would have is, if these are so effective, why haven't we been trying it before? Is it the historical reason?
Yeah, definitely.
The scheduling, the Schedule 1 nature of these drugs or whatever, Schedule 2, the stigma, that kind of stuff has made it incredibly difficult to study. Nobody was funding them. And if you started to touch this stuff, then you're like the old guys. Yeah. So it's tough. It is really tough. Who would want to put their hands on that stuff?
Exactly. And largely because you can't patent it. Yeah. Because it's been around since 1912. They cannot patent it. So yes, there can be some lucrative clinics and some well-meaning people that in these organizations that kickstart this kind of thing, but there's not billions of dollars of profit behind it by an individual entity that's going to, for all intents and purposes, ram this through.
Right.
Ram this home. Yeah.
The capitalist element of this is kind of diminished.
Yes.
Fair enough. All right. Well, changing subject. This is an email in from Brent, and you can email us, questions@askjoedimatteo.com. Hello, DiMatteos. I need help developing an appetite and putting on weight. I am 30 years old and work in construction. I never stop moving, usually lifting heavy flooring, lumber, and tools. Despite that, I have almost no appetite. I force myself to eat at least a couple times a day, nothing healthy, just whatever I can manage to cook and eat quickly. Chicken tenders and macaroni and cheese, oh, buddy, comprise a huge portion of my diet. I don't like most foods, and my interest in the ones I do like is usually gone after a few bites. I'm 5'6", and I weigh 125 pounds. Is there anything I can do to want to eat? Oh my goodness.
Well, thanks for the question, Brent. Yeah, that's that's definitely a tough one. So we'll try to unpack, what we can here.
Yeah.
I would say that, firstly, just looking at his BMI, he still falls within a healthy range. He's about 20.
Yeah.
So just at the outset, it's like, I'm hard pressed to say or have anybody or see anybody recommend someone to gain weight. Maybe if we were, 15 or 16 again, and you're trying to make the football team,
sure,
you got to gain weight. Those sort of situations are much different than, you're a 30-year-old, you're thinking about the long term, trying to maintain as healthy of a lifestyle as possible. There's rare situations where you're going to emphasize someone to gain weight intentionally.
So on the outset here, take the intensity down a little bit. You're probably okay.
Potentially. And I think that the other caveat there would be, we would not want him to miss if there was something else critical that would be causing a loss of appetite. So he doesn't go into detail if he has other symptoms potentially. I mean, it sounds like he's plenty energetic and he's obviously very active at his job and such, but is this weight, my question would be, is this weight that you've recently lost? Are you noticing a trend of weight loss, or have you been 5'6", 125 since you were 15? Has that just been your set point? Your happy point of weight and everything. Again, is this is this something that's potentially a symptom, a sign, or a symptom of something else that's going on? So potentially, if he says yes to some of those questions, then we sort of stop there, and we want to make sure he gets further workup beyond what we can actually address or even want to address.
What else could it be?
Well, that's tough. I mean, that's kind of
parasite from South America.
I mean, seriously, that's the kind of answers that we would be giving. It could be this, it could be that, it could be...
Okay, so it's kind of scattershot. It could be all kinds of different things.
Yes, but again, it's just distinguishing, is this weight that you've recently lost? Did you lose 10 pounds over the course of 2 months? Or again, is this, sometimes you're 125, sometimes you're 130, sometimes you're 122. Is it just is this sort of your natural happy place, which is fine. He's 5'6", 125 pounds. It sounds maybe light, just in sort of a conversational setting. But again, if he falls right within a healthy BMI range, which BMI is an easy screening tool. It's not the end all be all, but it's sort of a point that we just jump to quickly here. So assuming he answered no to a lot of those issues of this potentially being a symptom of something more serious.
So it really is just that he just doesn't like to eat.
Yeah. And again, there's genetic reasons, there's environmental reasons, that's just the way that certain individuals function.
Yeah.
There's the person that has been able to control their appetite their whole life. And that's like a gift. You know what I mean? Because there's so much in the environment here, and there's so many things genetically, that you're dealt, that it's just, that sort of stuff is harder for certain people, certain personalities, certain temperaments, certain whatever.
But if he's eating macaroni and cheese and chicken tenders,
that's probably that's much bigger.
Those are the hyper palatable foods. Those are not a good idea.
Right. Obviously. But what are we going to do? Brent, just stop eating chicken tenders, dude.
Yeah. I mean, well, that's a good point. It's not the point isn't stop eating garbage, and if you can't eat anything else, then I guess you just don't eat. Like, that's not where you're going with this.
Mm-hmm. Yeah, I'm just sort of piece by piece. My way of thinking. We haven't even gotten to the chicken tenders and macaroni and cheese yet. That's tough. I mean, we're talking about low. Like, what's the priority of how you look at a question like this? Does Brent have a serious issue underlying this?
Yeah.
I don't know. I don't know. We don't want to assume that he does, but we also don't want to assume that he does not, so that's the you start talking about weight, you usually hear it on the flip side. I want to lose weight. I want to lose weight.
Right.
We just don't want to overlook something like this, that he potentially is trending towards underweight for a more serious reason.
Okay.
But as far as like,
assuming that's not the case,
before, again, obviously we want to try to shift some of the types of foods that he's eating to the minimally processed stuff. That would be great. But as we know, with somebody who works a busy schedule, always on the go, not a ton of time to cook, this is the kind of stuff that's most readily available in your environment. So it doesn't really do him any good, do me any good to just say, dude, start meal prepping on Sundays.
Right.
That's super tough. It would be something that would be a conversation, very individualized. Start with making very small changes. Start with to the level of like, what is one vegetable that you can tolerate? Like literally, what is one vegetable? Pick any vegetable. You could pick any condiment to put on it to start. You could do anything. You just start.
If I cover broccoli in cheese, maybe I can eat that.
Sure. You start somewhere with those types of interventions. It's really tough because I'm sure everybody's been telling Brent, like, dude, you eat like crap. Like, try to eat more salads. Why don't you go,
right.
My gosh, that's how those conversations go. Everybody's got the best advice. Everybody knows what you should be doing, and it can be a little frustrating. So again, Brent sounds like an active guy. Sounds like he wants to put on some weight, whatever. I would say theoretically, we would try to focus on putting on muscle, ideally try to put on as much lean muscle as possible, which is difficult. When you gain weight, it's not just a clear cut, 100% lean muscle, especially depending on at what the rate is of the weight gain. But an easy way for him to up his calories would to just start with something in terms of liquid nutrition by way of a protein shake, a smoothie that he makes ahead of time, something that you have very tight control over versus ordering out food, takeout, trying to jump in the kitchen and be a master chef with all these different meal prepping options. Liquid nutrition and choosing one vegetable that he likes almost sounds like a very easy starting, a relatively low barrier entry point for him. So have the shake.
That's great.
Have the shake in addition to what he's already eating.
I didn't even think about that.
Just because we know that for most people, liquid nutrition, smoothies, trying to diet purely with something like that, it's just they're not satiating enough over the long term.
Right.
And so we want to leverage that for him.
Yes.
For somebody trying to lose weight, it's the opposite. We want to try to alleviate what you're consuming by way of liquid calories because you want to try to make yourself feel more full. For Brent, maybe we flip that on its head and try to just sneak in some cheap extra calories.
I like that a lot.
With quality.
But especially because I use our protein shakes in the morning. I always put a whole bunch of fresh spinach in there. And once it's blended up, you can't, there's no flavor. It's a weird color, but it doesn't taste like spinach. Yeah. It tastes like the peanut butter that I put in it. So
that's a great point too, because, rarely do we say have a greens shake instead of vegetables.
Right.
You're fine just doing a nutritional beverage instead of broccoli, instead of cooking your own food, instead of all these other things. But for in his case, we want to leverage that and say, hey, this stuff is still available. You're at the time in your life where a massive change sounds like it would be difficult. So start with some liquid nutrition in addition to what you're doing. Sneak in some greens, sneak in some reds, or sneak in something that's better than what you're currently doing. Yeah. And you just start to build this foundation of things so that it's not just chicken tenders and macaroni and cheese.
Right.
It's broccoli with cheese. And I'm also having this whey protein shake or plant protein shake that has a little bit of extra micronutrients in there that we still know is not as good as having the real thing. Yep. As far as how we assimilate those nutrients and such. But this is just the getting him away from the all or nothing. Right. There's still incremental things that he can absolutely do. He doesn't have to stop eating chicken tenders and macaroni and cheese.
Right.
But you start to skew the amount of those things and you start to replace those things with some of the other stuff we've mentioned over time, it can really, it can help over time, slowly.
I like it. I like that. That's very cool. I hadn't even thought about that. Brent, hope that helps. Well, we've been getting requests. This is so weird. You guys are fantastic and strange. We've been getting requests for us to talk about scripture. So that fell on me. And I had a great conversation with a good friend of mine who she was reading in Matthew chapter 15. There's a story of the Samaritan woman that's pleading with Jesus for him to heal her daughter. And a lot of people have trouble with this, and I understand why, and you will too if you don't remember it right off the top. The short story, I'll read it and then I'll tell you what we figured out as we were reading. This is Matthew chapter 15, verse 21. It says, "When Jesus left there, he withdrew to the area of Tyre and Sidon. Just then a Canaanite woman from that region came and kept crying out, 'Have mercy on me, Lord, Son of David. My daughter is cruelly tormented by a demon.' Yet he did not say a word to her. So his disciples approached him and urged him, 'Send her away because she cries out after us.' He replied, 'I was sent only to the lost sheep of the house of Israel.' But she came, knelt before him and said, 'Lord, help me.' He answered, 'It isn't right to take the children's bread and throw it to their dogs.' 'Yes, Lord,' she said, 'yet even the dogs eat the crumbs that fall from the master's table.' Then Jesus replied to her, 'Woman, your faith is great. Let it be done for you as you want.' And from that moment, her daughter was cured." All right, so there's a lot going on there. Cultural references that people need to know. If you don't know, the Canaanites were not Jewish. They were actually the historical enemies of the Jews. And so that gets pointed out here. It gets pointed out by Matthew, who wrote, shockingly, the Gospel of Matthew. But for most people at the time, they would have just said Gentile, aka non-Jew, which is anybody who wasn't a Jew was a Gentile. But that always felt insulting to this friend of mine, that he calls her a dog and he's just ignoring her. What's going on? Why would Jesus do that? Because that seems cruel. That seems unnecessary. And yes, he heals the daughter, but why be insulting? That doesn't make sense, right? So we started digging into it. We started reading, and I saw so many cool things. The first thing, and the thing that made the biggest difference, I think, is that Tyre and Sidon, Jesus had previously been, I believe, in Jerusalem. And this trip that he takes is about 50 miles out of his way. And it's not on the way to the next place he went. It was taking a left turn when he should have turned right. And he goes 50 miles that direction. Jesus was only on earth for 3 years, and he had to walk. So that's a long trip to take out of your way. The other thing is, we don't have any record of him doing anything else in that area at this time. So as far as we know, the only divine appointment that he had, the only reason he was in that area, the reason he walked 50 miles out of his way was to meet that woman. That's incredible. That completely changes the moment. Of course, this is the thing to remember. Jesus knows the end from the beginning. He knew what he was going to do. He knew why he was in the area. He didn't need her to say those things for him to know that he was going to do that, right? It wasn't like she said the magic words, "Okay, now I can heal your daughter." He knew what he was going to do from moment one. The rest of this is a setup to show us something, right? So I thought that was fascinating. Another fascinating thing, Matthew being the one that wrote this, he points out that she's a Canaanite. Anybody else writing the story or any non-Jew at the time would have just called her a Gentile. This was Gentile territory. It was not Jewish territory. So he is specifically going to Gentile territory. And it seems, based on the way that he says Canaanite, it seems that perhaps Matthew had an issue, or some of the other disciples had beef with her because they're the historical enemies of the Jews. So that's interesting, especially since Jesus would have known that going into this. So she's crying out, "Have mercy on me, Lord, Son of David." Another thing to point out there, Son of David, that's a prophetic name for Jesus. That is a name that means Messiah. That's a synonymous name with the Messiah. So this non-Jew is calling out to this Jew and saying, "You are the Messiah. You are the chosen one. I see that. I know," right? And Jesus is coming from a situation where he's constantly arguing with the Jews, the people that he's supposed to be, that should have recognized him. And so many of them, especially the highly educated religious ones, didn't, which comes in later in the story. So she calls him by a prophetic name, meaning right off the bat, she's got some level of belief that most of the people around didn't, which is pretty cool. Yet he doesn't say anything to her, because sometimes, this is another relevant point, sometimes when we ask for something from God, when we're praying for something, sometimes the answer is not an answer. It's just silence for a while. Maybe it's not quite the right time. But she's annoying the disciples, and I think this is really fun. She's annoying the disciples with the way she's crying out. And the disciples then go to Jesus and say, send her away because she cries out after us. The verb that is there for send her away is used again in Luke. And in that context, the send her away is send her away satisfied. Just do what she wants, because good golly, we're annoyed with this woman. Can you just, you're God, we know that, just do what she wants and get rid of her. And so the first response that he offers, and in fact, both responses presumably are to the disciples, not to her, right? He says to the disciples, I was sent only to the lost sheep of the house of Israel, which was why he was there. That's why he came, was for the Jews, right? And I think he's calling out from them some recognition on their part. He's going, look, you know why I'm here, but it annoys you so much that she wants help that you're willing to take me off course? Because my job is not to seek to heal all the Gentiles as well. That was going to happen, but that was the disciples' job. That's what he commissioned them to do, is then to take the story out to the Gentiles. And I think it's fun that he's kind of poking them, going, wait, you know I'm here. You want me to go off course for this? And they say, and then she reiterates again, Lord, help me, which is like the perfect prayer. Well, I won't go down that path, but there's a great sermon about how that's like the perfect prayer. Lord, help me. And this is where the real meat happens, where people have real issues with it. It isn't right to take the children's bread and throw it to their dogs. So he's calling her a dog? Well, okay, there's a couple things here. First of all, sort of, kind of, not really. The racism of the day, that's how they would have addressed her. That's what they would have called her. And is it gross? Yeah, because racism is gross. That's the point. I think the real problem is, because he's talking to the disciples, and no doubt, especially from the fact that Matthew's pointing out she's a Canaanite, there was some sentiment of that in the group. So he's kind of calling out their own issues. He's not talking to her. He's talking to them. I think he's pointing that out. And then the other thing that's worth pointing out here is the bread, that which he had to offer, had already been rejected by the Jews. And that's what she points out. I just want the crumbs. If they're not going to have it, can I have it, please? I think the other thing that's really fascinating here, that I don't want to say it does a disservice to us, but it stinks that we can't hear Jesus's tone of voice. Because tone of voice, the inflections can change so much. If I say, I love you, versus I love you, right? That means totally different things. And we can't hear the way Jesus is saying these words to her or to the disciples in that moment. So we don't know if he is doing it with a wink and a nod, looking at her going, watch this, I'm going to rib them, or if he is legitimately being a bigot. I don't think that's the case, because we know that's not who Jesus was. So it stinks that we can't hear the tone of voice. I think that would alleviate a lot of people's concerns with this particular verse or chapter. The big punchline at the end, though. Jesus replied to her, woman, your faith is great. Let it be done for you as you want. There are only 2 instances in the Gospels when Jesus specifically honors someone's faith. Only 2. And neither one was to a Jewish religious leader or even a Jew. It was the Roman centurion, and it was this woman. Those are the only 2 people that he commends their faith. There's the other woman who gets healed from her bleeding. That he says, your faith has made you well, but he doesn't specifically say, your faith is great. He only says that twice, and she is one of the 2. Once I knew all of that context, especially that he's going 50 miles out of his way just to meet her, completely changed the way I read that story. And and I love it. And I encourage anyone who is feeling challenged by a specific story or section of the word, dig into it, find out. There's a lot of great commentaries out there. There's a lot of really interesting stuff. And the more I have learned about difficult passages like that, the better it has made my entire experience. So,
yeah, there's no way I was able to, whenever you first started reading it, I didn't know exactly where you were going. I didn't know exactly what he meant by that at all.
Yeah.
Yeah.
If you don't know the context, it just feels gross.
Yeah.
You know, somebody in distress and he calls her a dog. That's not cool. But I think digging in always helps. That is it for us this week. All of our products are available on our site, askjoedimatteo.com. That site is also where you can sign up for our newsletter. You can find out about what's on sale. You can find old episodes of this show or the original show that started all of this, Ask Joe DiMatteo, all there on our website. If you have any questions, we want to hear those. Email us questions at askjoedimatteo.com, askjoedimatteo.com. That's the website. Show notes are going to be available down below each episode, whether you're listening to it or watching it, they're there. And if you are only listening, do check them out on YouTube and Rumble. You can watch the video. It's a lot more fun, I promise. Big thanks to Josiah Schweinberg, who's behind the cameras making us look good. Michael Deppish, our editor. Joyce Gibb, the nurse practitioner who handles private consults. Diane Silverman, manager of products. Terry, who does scheduling. Cecilia does distribution. Joey DiMatteo, Dante DiMatteo. I'm Tyler Andrews, and that is it for us this week. Now, it is turned over to you. What are you going to do with what you've learned today? Are you just listening and being entertained, or are you going to take action and become part of this Generation Health?